Welcome back my friends. So this will be our final topic in case of congenital heart diseases. After completing this we will go with congestive heart failure or valvular heart diseases depending on the situation. Okay. So today we will learn about coarctation of aorta. So basically coarctation of aorta is also a cyanotic heart disease because here cyanosis will be present. And to be precise, it will be differential cyanosis. Okay, what do you mean by differential cyanosis? That means the lower part of the body will become cyanosed, whereas the upper part of the body will remain pink. That means it will be normal. And differential cyanosis was also a feature of one more disease. Can you remember that? That's the Eisenmenger syndrome developing in a setting of patent ductus arteriosus. Okay, I had depicted there in detail how it develops. If you haven't watched that, you can go and visualize that video. Okay. So coarctation of aorta is also a cyanotic heart disease where differential cyanosis will develop. Now, what do you mean by this coarctation? Generally, we think that coarctation means narrowing of aorta, right? But that is not the direct meaning of a coarctation. The proper meaning of coarctation is something to draw in, something is indenting upon it, or to be specific, the wall of the aorta gets drawn inwards into the lumen or it gets indented into its lumen, which causes narrowing. Can you get my point? So basically the wall of the aorta gets drawn inwards into its own lumen, obstructing the lumen. Okay, that is the meaning of coarctation of aorta. So basically narrowing of aorta occurs, but it is due to indentation or drawing in of aortic wall into its lumen. I will show you a diagram, don't worry about that. And remember one more point, coarctation occurs near attachment of ductus arteriosus. You know this ductus arteriosus is an artery which connects the left pulmonary artery to the descending aorta in case of intrauterine life, right? And near to the attachment of this only the coarctation of aorta will occur. Either it can be preductal or postductal, that we will see in a few moments later. And if you talk about the incidence, male is to female ratio is 2:1. That means the incidence of coarctation of aorta is more common in males compared to females. And if it occurs in females, it will be associated with Turner syndrome. Okay, and it's basically a cyanotic heart disease, we know this. Okay, now let's go to the main pathophysiology of coarctation of aorta. Yeah, you can see here, this is what I was telling you now. The aorta wall, you can see here this aortic wall, it is getting inside. That means the wall of the aorta is drawn inwards into its own lumen. So you can see here the lumen gets narrowed or it gets obstructed, which obstructs the blood flow finally. Okay, so this is the basic definition of coarctation. And this picture is taken from generally Wikipedia. Okay, so some points will be present in Wikipedia which will not be given in any of the books. Okay, so now go to the pathophysiology now. So you can see the heart, same thing, and you have this aorta which is arising, aortic arch, then this is the descending aorta. Okay, and here you have the pulmonary trunk which gives the left branch and the right branch. This is the left branch and this is the right branch of pulmonary trunk. And in the aortic arch, I had said you before, there are three vessels, that is subclavian artery arising laterally and left common carotid artery. This is the left common carotid artery. And in the right side you have this brachiocephalic trunk. This is the brachiocephalic trunk which divides into right common carotid artery and right subclavian artery in the right side. Okay, so these vessels arises directly from the aortic arch. Okay, now what happens? You can see here ductus arteriosus I had drawn in black color. This is the ductus arteriosus which connects the left pulmonary artery to the descending aorta. Now I am discussing about preductal type of coarctation of aorta. You have three types of coarctation of aorta basically. One is the preductal type, second one is ductal type, and the third one is postductal type. Okay, so preductal type refers to the coarctation of aorta that occurs proximal to the attachment of ductus arteriosus. So if you see here, the ductus arteriosus is attaching at this point. This is the point. Okay, this is the point of attachment between the ductus arteriosus and the descending aorta. Now the preductal type of coarctation of aorta will occur proximal to the attachment of this. Thus means somewhere here you will have the indentation. That means the coarctation of aorta will occur little proximal to the attachment of ductus arteriosus. Now as you can see here, the blood flow which is coming from the left ventricle, I am drawing with this color, see, left ventricle, it goes through the aorta and it will travel via these vessels, that is subclavian artery, common carotid artery and the brachiocephalic trunk easily. So the upper part of the body, that is the upper limbs and the upper half of the body, will receive oxygenated blood normally. There will be no problem at all. But due to this coarctation of aorta, this oxygenated blood will not be able to pass into the descending aorta, right? So the lower half of the body will not receive this oxygenated blood. Okay, but remember here, the pulmonary artery, the deoxygenated blood which is coming from the right ventricle will pass through this pulmonary artery, then left pulmonary branch, and then via this ductus arteriosus it will go into the descending aorta. So by this what you can infer, generally the deoxygenated blood which is coming from the right ventricle is entering the descending aorta, and the lower part of the body is getting only deoxygenated blood. Okay, so that cyanosis will occur only in the lower half of the body, whereas the upper half of the body remains pink, that means normal. Okay, this is the case in case of coarctation of aorta. So in short, in case of pre-ductal type, the oxygenated blood is not reaching the lower part of the body, only the deoxygenated blood is reaching the lower half of body, but the upper half of the body is receiving oxygenated blood normally from the left ventricle. Okay, now tell me one thing, whether in this condition collaterals will develop easily or not, because as you can see, the upper half of the body is receiving oxygenated blood and the lower half of the body is also receiving blood, even though it's deoxygenated blood, but the blood is going to the lower half of the body also via the pulmonary trunk. So in this condition collaterals will not develop properly, so the development of collaterals will be poor or it will be negligible. So the clinical features will be present early in life. That means the cyanosis and some other clinical features which we will be discussing in few moments later, that all will be present in the early stage of life. So ductal type of coarctation of aorta is also called as infantile type of coarctation. Okay, that is the infantile type. Okay, let's go to this topic now. So we had discussed in detail about the pre-ductal type. Now coming to the post-ductal type of coarctation of aorta. Suppose the coarctation of aorta is present postductal here. Postductal means it is distal to the attachment of ductus arteriosus, somewhere here, right? In this condition, as you can see, the oxygenated blood from the left ventricle entering the aorta and going to the upper part of the body normally. Here also the upper half of the body is receiving normal oxygenated blood, there is no problem, and it is not passing through this coarctation of aorta, not able to pass this narrowed lumen, and the lower half of the body is not getting oxygenated blood here also. But remember here, in this condition, the blood which is coming into the pulmonary trunk, that is the deoxygenated blood, it will go via this. But here you can see, as the coarctation is distal to the ductus arteriosus, the deoxygenated blood also will not be able to go through the descending aorta. So the lower half of the body is not receiving any blood. That means neither oxygenated blood nor deoxygenated blood it is able to receive. Okay, if it is receiving very little amount of blood. So what happens here, collaterals will develop at an early stage. Okay, the body tries to compensate it by opening up all the collaterals in the body so that the lower half of the body can receive the much amount of blood, right? Symptoms will not be present at an early stage, it will develop at the later stage of life, that is during adolescence. Okay, so only we call pre-ductal type as infantile type of coarctation, whereas this post-ductal type is called as adult type of coarctation. Why? Due to this reason only. The opening of the collaterals will not occur in case of pre-ductal type, so the symptoms will persist in the early stage of life, whereas in case of post-ductal type, the collaterals open up early and all the collaterals will get opened up early, so the symptoms will occur only during adolescence. Got it? And one more type is there, one more type of coarctation is the ductal type, that will occur at the level of ductus arteriosus here. Attachment of this ductus arteriosus, we will develop this, but it's not that much significant to discuss here. Okay, so now the same thing, just a short recap. It is due to the indentation or drawing in of the aortic wall into its lumen, that we know the concept. Now there are three types: pre-ductal type, that is infantile type, and the ductal type and the post-ductal type. The post-ductal type is the adult type. Why this infantile and adult we had discussed in detail. Now pre-ductal type, oxygenated blood will not be able to pass through the aorta, right? But the deoxygenated blood is able to pass through, and here collaterals will develop slowly and the cyanosis will occur at an early stage. So it is called as infantile type of coactation. And the ductal type, you can see at the level of insertion of ductus arteriosus this occurs. Coming to the postductal type, we have the oxygenated and the deoxygenated blood. Both will not be able to pass through the coactation as we had seen in the diagram. So what happens, the collaterals will open rapidly, their body tries to compensate it by opening all the collaterals. So symptoms will not be present at an early stage, it will develop at the later life. Okay, and one more thing, as the upper half of the body is receiving more amount of blood, hypertension will occur in the upper extremities, whereas the pulses will be weak in case of lower limbs. These are just physical findings. Okay, now coming to the clinical features, remember that most of the patients of coactation of aorta will be asymptomatic, but if they develop symptoms, they will have pain and weakness of the lower limbs. Obviously, as the blood supply to the lower limbs gets decreased, they will experience pain and weakness. And coming to the cyanosis of the lower extremities, that is case of differential cyanosis. And the headache and fatigue, as the blood supply to the brain decreases, it leads to headache, fatigue and dizziness. These sort of symptoms will occur. Now, what is the complication? See, there are some 3 to 4 complications mainly, which I will be discussing now, related to kidney, related to heart, related to lung, etc. Okay, so what happens in kidney? See, generally the lower half of the body is not getting blood, right? So what happens? Renal blood flow decreases. Renal blood flow will decrease. As the renal blood flow gets decreased, the juxtaglomerular cells will produce more amount of renin, right? So renin is released into circulation. Now this renin will activate angiotensinogen into angiotensin 1. Angiotensin 1. Okay. Now what happens after this? The lung will produce one enzyme, that is angiotensin converting enzyme. This will convert the angiotensin 1 into angiotensin 2, right? Now this angiotensin 2 will cause vasoconstriction, as well as it will stimulate juxtaglomerulosa of adrenal cortex to produce aldosterone. Okay, so aldosterone will be produced from the adrenal cortex. Aldosterone. What this aldosterone will do? It will go to the distal convoluted tubule as well as collecting dirt, and it will activate this epithelial sodium channel, that is ENaC channels, right? Through this epithelial sodium channels, more amount of sodium will be absorbed and the potassium or the hydrogen will be excreted out. Okay, as more amount of sodium is coming in, along with the water also comes in, that is obligatory water transport. So this increase in sodium and water retention in the body causes plasma volume expansion. As the plasma volume gets expanded, hypertension develops. Okay, so the one more characteristic feature in case of coactation of aorta related to kidney is hypertension development. Okay, that's what is given here. When the RBF, the renal blood flow decreases, renin-angiotensin-aldosterone system, that is the RAS system, gets activated. When it gets activated, angiotensin 2 will be produced, which causes vasoconstriction and also stimulates the adrenal cortex to produce aldosterone. Okay, so now what happens? This aldosterone will cause the sodium and water retention, and then plasma volume gets expanded, leading to hypertension. Okay, now the second feature is congestive cardiac failure. As you know, the blood is not able to pass through the coactation area. That means the narrowed lumen is not allowing the blood to get passed through. So the blood gets congested or gets accumulated in the chambers of the heart, leading to congestive heart failure over time. Okay, and coming to the pulmonary congestion, obviously when the left ventricular pressure increases, it causes back pressure in the left atrium. Then again that in turn causes back pressure in the pulmonary vasculature, which causes pulmonary congestion and pulmonary edema. The symptoms will be like shortness of breath or chest pain, etc. Okay, now coming to the physical findings, this is absent or feeble femoral pulse. Obviously the lower half of the body is not receiving enough blood, lower limbs is not getting enough oxygen, enough blood, so that's why we get a feeble or absent femoral pulse. And the BP will be obviously high in case of upper limb, and there will be radiofemoral delay if you measure, and the differential cyanosis, that is a characteristic feature of coactation. Okay, so now coming to the treatment part, if the patient develops congestive heart failure, we can treat him with giving diuretics and digoxin. Okay, and also we can infuse prostaglandin E1. Okay, this is prostaglandin is infused so that the patency of ductus arteriosus should be maintained. You can see here, through the ductus arteriosus only, the deoxygenated blood, even though it's a deoxygenated blood, it was able to bypass the coactation and reach the lower half of the body. Okay, so to maintain this ductus arteriosus, it's better to give prostaglandin E1 infusion, and the surgery will be balloon dilatation angioplasty. it is not little bit visible here. Okay, balloon dilatation, angioplasty. You will insert a catheter, right, and through that catheter you will inflate that balloon so that the coarctation the indentation gets removed. Okay, so suppose this is the wall of the aorta, it's indented like this. Okay, it's the wall had drawn inwards into it, so the lumen is obstructed here. If you put a balloon and if you try to inflate the balloon, it will be like this, right? You have dilated this, so the aorta gets dilated and the blood can flow through this easily. That is the surgery part. Okay, so with this we had concluded our session of coarctation of aorta. Hope you liked it, enjoyed it. Thank you so much. See you in the next lecture.